Hello, everyone. I am Pat McDonald. I've talked to some of you by email and phone on a number of occasions. Dr. Spurtis was going to Zoom in to do to kick us off, but he had to go to San Diego, and I just got a text. He had planned to Zoom in from San Diego, but something's come up. He's tending to some family matters, so he is not able to be there. And our colleague Stacy Farr is away at a really exciting conference, and so she's not here. So you all are stuck with me today. Thank you to all of our presenters who said yes. As all of you know, we're the Healthcare Institute for Innovations and Quality, and we test processes for whether they will reduce costs, improve equity, and create a better experience for the provider and the patient. And all of this is focused on the Kansas City region. That is our primary core business. We also love bringing the community together like we're doing today with our IQ forums to discuss critical issues affecting our Kansas City region as it relates to healthcare. Many of you helped us pick this slate of subjects for the year, and in August, you'll probably get another large survey, and we'll welcome your help picking next year's schedule too. John, as you all are used to, gives a wonderful entrance in opening to our forums. But as I said, you're stuck with me. So I'm going to read from a prompt here about generative AI disruptions and advances in healthcare. But before I do, I really want to acknowledge our sponsors, our supporters, because we wouldn't be here without these wonderful people here, the Health Forward Foundation, BioNexus KC, the University of Missouri, Kansas City, and Frontiers. So please help me thank them. You don't have to clap or anything, but, but we are very grateful to them. And our presenters today will be bioethics perspective, AI ethics in healthcare principles to practice, Lindsay Jarrett, Vice President, Ethical AI Services, Center for Practical Bioethics, Clinician Perspective, Generative AI in Healthcare, Challenges and Opportunities with Dr. Amy Patel, breast radiologist and medical center, Breast Cancer Center, Liberty Hospital, Chairman, Liberty Hospital Cancer Committee, Associate Professor of Radiology at the University of Missouri, Kansas City, and so much more. Like the rest of our presenters, Amy, I don't mean to cut your title short, but like all of our presenters, Amy is doing a lot all over the Kansas City region. Public health policy perspective, developing AI policies, a practical guide to ethical use in public health with Emma Udridge, analyst, Kansas Health Institute, and industry association perspective coming from Samantha Birch, Vice President, Technology, Public Policy, America's Health Insurance Plans, AHIP. She'll speak on health plans, AI use cases, and policy perspectives. And I'm so grateful to all of you for saying yes to being here with us today. And with that, Lindsay.
Thank you, Pat.
Thank you. Okay, I'm trying to stop sharing. Here we go. Oh, no, I have to stop the share to pull yours back up. And where are we? Do you spot yours?
Yeah, they're in the bottom left. You just have to start from the beginning. Speaking of funders, thanks for all of our funders that are on this slide. But I don't have to talk about it later.
And I will let you take the wheel. Thank you, everyone.
Good on the sharing aspect of it. Yes. Okay, perfect. Yes, so thank you so much for the introduction. I'm going to move this down just a little bit. I was not given great height. So I am going to, I'm going to try to keep my section kind of brief. I think it's hopefully going to give you a little bit of overview of just the topic area. And then I hope to set all of my other speakers up for success as they sort of get into some of the details of the work. But I'll help in sort of kicking us off as we sort of think about this topic area. I do want to also say that I do work at a bioethics center. I've worked there for about 5 years now, but I am not an ethicist. I'm a social scientist. I feel very close to the ethicist realm, but I would not say that I am an ethicist, but hopefully I bring sort of that social science perspective and sort of the ethicist perspective. I also am a previous data scientist and clinical researcher, and a patient. So hopefully I bring all those perspectives as I talk through this. So I'm going to briefly just sort of explain AI. This is not a technical presentation, so I'm not giving you a lot of those pieces. I think we'll probably have some technical examples as we move forward this afternoon. But really the work that I do is really having discussions around the systems that create and ingest AI. And I really talk with people that are impacted by it. So I'll talk about, some AI use cases in here in health and healthcare, and hopefully outline some potential benefits, but I'll also describe some risks and potential harms with AI in healthcare, and I'll sort of outline those steps as well. But when we really think about how AI is defined, a lot of folks talk about AI differently, and it can be mapped back several decades ago, but it continues to be redefined and reimagined. But AI at its simplest form is the science of making machines that think like humans. It is work to mimic almost every person, from chess players, assembly line workers, judges and lawyers, to food delivery drivers, teachers, musicians, artists, and healthcare providers. And I think we're still in the space of, has it achieved this? And I think it depends. So when we talk about AI sort of in this new sort of ChatGPT space, right? We're kind of in this post sort of era in thinking about AI in sort of this new way. I think we give AI a lot of praise, so much so that I think we think it does more than it really does. We're sort of on this global journey to create technology to serve us and possibly surpass us. We're sort of in this race. And I think it's been this case since 2002, especially tech companies have really been in this race to create the best prompting tool for the everyday consumer and professionals, creating the idea of agents, tools like Siri, the thousands of chatbots we encounter, and platforms to help us get information quicker and with little human interaction. But honestly, we're still struggling with this. So this visual is not meant to be negative. I think it's just a good spot for you to sort of have a reality check of kind of where we're at with technology, and especially with AI today. So I think in healthcare specifically, and healthcare technology, we've been having somewhat of a slow burn outside of the traditional electronic health record offerings over the last 15 to 20 years. But I think in the last 5 years, we've sort of seen an uptick in the areas that the healthcare industry are willing to sort of try on advanced technology and AI-enabled products. I think we've seen tremendous growth in using AI to assist healthcare organizations with operations. A lot of organizations are already using AI-enabled products to assist them in cost and efficiency, resource allocation, transcription. And then I think also as a result of the pandemic, we've seen several chatbots, virtual therapists, and virtual health options emerge. And I think that we see a lot of promise in AI for healthcare. And I think it still depends on when it is used, how it is used, and who is impacted by it. And I think there are 4 areas that sort of stick out. And I think that there are specific sort of evidence that sort of points to these benefits in healthcare. And I think these are growing every day. We're seeing different use cases sort of come out of these spaces. We're seeing a lot of promise in diagnostic AI, especially with imaging, radiology. We've seen a lot of promise over time with robotics. We continue to see a lot of promise with telemedicine and remote monitoring, especially as people can track their own health and wellness in the luxury of their own homes. And then I think when we sort of take those benefits and we sort of think about, well, what's on the other side of that? We can be really thrilled about this, but what are the things that we should start to think about? And I think that there are a lot of people that are thinking about this space. And so ethicists, social scientists, researchers, and technologists have really found that this ethical problem space for AI can really be described in these 3 areas. It's a Venn diagram, so the intersections are important. But I think it's important to sort of think about these three areas when you think about this black box problem, right? It's hard to interpret. It's hard to interrogate a lot of the things that are inside of these models, inside of the insights that come from these models, and how do we kind of understand that and how problematic that might be if we don't. Also, mirrored biases is something we talk about all the time. It's this idea of garbage in, garbage out. So how do we think about the data that's sort of coming in? Is it perpetuating systemic bias? Is it perpetuating faulty decisions we've been making already? Is that important? Are there data flaws, right? Data integrity fits in here too. And then I think the last one I think is really important when you think about healthcare in general, and think about technology sort of in this intersection, is that we don't want to diffuse the responsibility of providers or even maybe users in general, and that it really is acting as this external agent, but it might be diffusing sort of responsibility away from operators themselves. And I think when we think about risks and when we think about these things that might happen sort of inside of that problem space, there's a lot of common themes that emerge, right? We think about, perpetuating health disparities, sort of reproducing a lot of systemic bias that already happens in the data and care delivery. Denial of service is a really big one. This is something that ethicists are tracking all the time. It's probably been an issue without technology, and now it's an even bigger issue with technology. Payer groups have been pretty eager and early adopters of AI. What does that mean for people on the other side, right? What does that mean for the people that are impacted by those decisions? Automation bias. Are we just saying yes because it's automated and seems easier, right? Is there bias in that as well? And there's also things, data privacy and integrity are important. I think we talk about actually this a lot, and we talk about it a lot in the tech space and with technologists in general. But I think these ones here on one size doesn't fit all, and opaque clinical recommendations have a really big risk of really just understanding, are these tools actually contextual and meant for the people that are using them and they're being developed for? So I think these are important sort of considerations when you think about the risks that are associated. And a lot of the things that the work that I do in the community sort of poses this question. I work with a lot of healthcare leaders in, not only thinking about what can we do. I'm actually pro-technology. I'm a social scientist. I know that it means that we can be innovative and that we need to embrace this technology and this movement forward across our society. But sometimes we forget this question of what ought we do? And it might give us some pause in thinking about what are the policies, what are the guardrails, what are the considerations that we need to be thinking about, and not just thinking about, let's do it. Like, I need to save money and it seems like it's working and, it's cheap, or some other hospital has success with it, so let's do it. And so I have a lot of these kinds of conversations about, well, what ought we do? What are the considerations? What are the things that you're sort of concerned about? It's natural to be excited, but what are the things that give you pause, and how do you kind of build some systems around that? And then a lot of other folks are having this conversation. I am not alone. It's really nice that I don't feel alone in this at all. And there's a lot of really great folks that are doing this work and are really championing a lot of the ideas around AI ethics. And so I'll just sort of leave you the next couple of slides with just some ideas of how you can sort of think about principles to practice, which is a lot of the work that my team does at the Center for Practical Bioethics with healthcare organizations, of thinking about what are sort of those principles, especially when you think about the values that might exist in your organizations, but also the values that exist inside of an industry like healthcare and why that's important. And there are some pretty distinct values and principles that exist in healthcare. Providers have to stand by them, they take an oath to them. And so how can we sort of think about that in connection to technology and advancing that technology forward? And there's some things on here that I think are they've been moving since 2018, especially when you think about privacy, accountability, and transparency. But we sort of often lack what is like, how do we actually take those principles and put them into practice? And so a lot of the work that we do on the ground is really figuring out what are the systems that you already have in place and how can we start to insert sort of these ethical questions and these ethical checkpoints along the way. AI literacy is really growing. People are starting to talk about what that means for organizations. Does that mean you educate all your staff? Are there certain staff that have to have this education? How do your patients, how does the community understand AI? So just thinking about those and then being able to also take that, I thought about making this a loop. It could probably be created as a loop, but I also very much know that most organizations still operate in a very distinct hierarchy. And so that's important when you sort of think about powers and decisions. And so when you think about that, there's also has to be opportunity for you to think about these protocols and to think about how you might put some things into practice inside of your already existing values and principles. And so I think that it's just important as you kind of move forward to sort of think about what it looks like to sort of bring all these connectors into play across organizations, and I think across the healthcare industry as a whole. So we have to sort of understand the problems that we're trying to solve. AI might actually not be the solution that you need, but it might be, right? But what are the questions that you're asking yourself and the things that you might need? And then also building, those policies and procedures for your entire life cycle. AI doesn't just start on the desk of a data scientist or an analyst or a chief technology officer. A lot of those decisions are already made and bought and sometimes developed by the time a data scientist or an engineer sees them. So what are the things that you're sort of putting in to your policies to make sure that you're understanding the ethical implications? And then also just ensuring that you're continuing to evaluate those tools and monitor them and gather feedback, just like you would across a lot of other things in your organization. And then I think we have some things to learn just from some of our global partners that I think are doing great work. So again, just take time to understand the tools, ask what tools, like people around you, people that you're working with, yourself, understand those tools. And then ask yourself how they benefit you and how they might actually put you or someone that you're working with or caring for at risk. And then I always end with this slide. I just think that ethical technology impacts all of us. I'm in this work for a lot of reasons, and a lot of these people can't stand here with me today because they've been at the impact of health conditions that they weren't able to get through. And so I hope the technology has a space. Some more people that I love can be well and that we can move forward with our healthcare. Thank you.
Thank you, Lindsay. That slide, risks of common themes, that slide really pulled me in. Reproduction of systemic bias, automation bias, data privacy, and opaque clinical diagnosis. That really pulled me in. And those online, please begin dropping your questions in the chat. I am sure you'll have many. So we'll have a really great conversation after if you start dropping your questions in the chat. And before I invite our next presenter to the mic, I want to remind everyone that registered for the meetup this evening, that you signed up for a meetup this evening, and at the invitation of Digital KC, and we're very grateful for that invitation. So all of you are invited, but you were supposed to register, are invited to the Grand Falloon from 5 to 7. So I'm sure everyone will have a good time there. Let me get the next slide going for you. Don't you miss John Spurtis and Stacy Farr?
You're doing great.
Dr. Amy Patel. Trying to get you into presentation mode.
Oh, I can do that.
Okay. I think you're going to need that.
Yeah, I'm gonna get this out of the way though first. Okay. Okay. And move this kind of out of the way too. Make more sense to do here. We'll see. Okay. All right. Well, thank you so much, everyone, for having me today. I'm really excited to talk about a very sort of brief overview of particularly when it comes to healthcare and generative AI. I think Lindsay teed us up really well for this discussion. And so I'm going to focus more of my discussion today on how I'm using AI in clinical practice and what I'm seeing since we've implemented a certain AI algorithm since 2019. So I'll focus a little bit more on that. These are my disclosures. Okay, so I won't get, this is a very intelligent crowd. I didn't know the exact audience today, so I'm going to, I will spare you of, what AI is. As far as generative AI is, generative AI is different in that it was designed, obviously, to create novel synthetic data. And it describes algorithms that can be used to create new content like code and audio, as we know, videos, images, text, simulations. And we're seeing at a very rapid rate a launch of new tools, iterative technological advances. As a breast radiologist and as a radiologist, diagnostic radiologist, I see this rapidly happening, new algorithms that are coming out on the forefront all the time. And, AI adoption has more than doubled over the past 5 years, as Lindsay sort of teed up, that we're seeing just a lot more steam in this front. And investment in AI is also increasing. And it's particularly showing promise in healthcare, as we all know. So as far as healthcare goes, it has immense potential to enhance patient care. All of us as physicians, whether we're in radiology, we're in primary care, any of the other subspecialties, we are facing an immense workforce shortage with no end in sight. Burnout is at an all-time high. Fatigue is at an all-time high. So what can we do to help us be better at what we do? I am in the line of thought, like a lot of physicians, and you might have seen a New York Times article that just posted or just published, I believe it was yesterday, that talks about AI enhancing what we do as physicians, but not replacing us. But previously, that thought leader wrote about replacing us, but I think he ate his words, ate crow. So we were all really excited yesterday. We're like posting it on all our forums. We're like, see, like this guy's a joke. But anyway, we're just glad that he finally, fixed what he was saying. Streamlining operations, accelerating research, and improving accuracy of medical image analysis. And that's the part that I will be focusing on and showing you what we're doing in our clinical practice. So in my field of radiology, about 50% of radiologists now are utilizing AI in some form, whether it's for clinical diagnostic, clinical decision support, or like a second opinion consult like we're using, whether it has to do with workflow automation, whether it has to do with scheduling. So clinical documentation and workflow automation has great potential to automating tasks like note-taking, report writing, summarizing patient interactions, has a lot of potential to improve the efficiency. Often at the end of the day, physicians have just a slew of notes to write. They're exhausted. They're like, I don't want to, even deal with this. And then we're late on our notes, and then we get flagged that we're late on our notes. So this has, huge potential to help us with our efficiency and reduce clinical burnout. Can assist with scheduling and triaging critical cases on work lists. Particularly in my world now, we're seeing AI mammography algorithms where we have a work list and it can actually triage you and show the most critical cases at the top of the list. So those cases that have malignancies, we can triage these patients and get them in faster for their callback, for their diagnostic workup, for their biopsy diagnosis, and their treatment. So that is a real world thing happening, particularly in breast radiology, which has been really helpful. You might have a list of maybe 200, 300 screening mammograms. What can we do to improve our efficiency to get the most critical screens at the top of the list so we can get those patients in faster? And then generative AI tools can formulate medical records and has the potential to suggest differential diagnoses and treatment plans. So we're practicing now in an era of personalized medicine, and especially in breast cancer care, we're in this era of precision personalized medicine and risk-based delivery of care. And so, AI models can analyze genetic, lifestyle, clinical data to tailor treatment plans for individual patients. Predictive modeling is enabling early diagnosis and intervention, particularly with chronic diseases. Generative AI tools can help even formulate medical records and suggest differential diagnoses and treatment plans. And particularly in my world, we're seeing AI algorithms being formulated where we can predict if there's concurrent invasive breast cancer in a patient who might have what we call like a pre-invasive malignancy. We can also predict maybe the patient's chance of having metastatic disease or spread to the lymph nodes from the breast. So we're starting to see some really interesting algorithms that can help predict or even predict their percent risk of having breast cancer in 5 years, 10 years. So we're seeing all of that right now related to generative AI tools. So Lindsay talked about medical research and drug discovery, incredible implications there, even something such as a literature summarization tool. So, as a breast imaging specialist, I feel it is important for me to keep up with the literature. And there are so many manuscripts getting published at a rapid rate. And with our busy clinical schedules and all we do, how do we keep up with it? Well, you can use AI to help summarize and help you essentially figure out which articles are cutting edge, which are the ones that we need to keep on top of, and go through in the vast amounts of scientific data. Lindsay also talked about this. Chatbots and personal assistants can provide patients with reliable health information, potentially medical reminders, and even emotional support. And I think, as a clinician, multilingual support to improve accessibility for diverse populations, I think that is huge. We have a huge interpreter shortage in health systems, not just in the Kansas City metro, but all over the country. And more patients, our patient population is becoming more diverse, and more patients are walking in the door where we may not even be familiar with the language that they speak. So for me, from a clinician standpoint, having that multilingual support from generative AI algorithms truly is a game changer so we can best communicate with these patients. As far as medical imaging and diagnosis, which I'm going to be focusing on, so what's been really amazing is generative AI can enhance and synthesize medical images for training or support diagnosis when the data is limited, and supporting precision diagnostics as well through image segmentation and anomaly detection. So in my field, we've got a lot of AI algorithms that are out there right now. And one that we are particularly using at my practice is AI breast ultrasound. And I wanted to show you what this looks like. So this AI breast ultrasound algorithm, we actually introduced it in 2019. So I used to practice on the East Coast in Boston, and I was really fortunate to work at Beth Israel at Harvard, working with MIT researchers, and it was amazing. And I was actually gearing up to implement this tool at the BI, and then an opportunity came to come back home. I'm originally from the area, to build a breast program here at Liberty. And so with that, I brought AI. So this is an AI breast ultrasound algorithm, and it's based on over 1 million studies with a radiologic and pathologic correlation. And it analyzes your finding based on about 17,000 areas of interest. So the way this works is this is actually embedded in our PACS system, the system, where we read our images. And it was we worked very closely with the vendor, and our IT team worked with the vendor to implement it, which was a very pretty easy process. Now, as far as this is used, so what happens is we launch the algorithm on our PACS system. So it's a quick launch. And then once it's launched in our PACS system, you have to bring up the images in 2 planes. So in our world, we scan patients either transverse sagittal or anteradial radial. So you have to have 2 planes, and you look at a lesion of interest. So that you want to analyze. We don't analyze every patient because some patients are very straightforward. That's a simple cyst, that's a benign mass. We don't need to analyze this. It's the cases where we need that second opinion consult, where maybe we go, I'm not really sure, like this might be benign, but I could say this is probably benign, which is a greater than 2% chance of malignancy. Or maybe I want to, biopsy it and give it a low suspicion of malignancy, which is a greater than 2% chance it's a cancer, but less than 10% chance. So it really kind of helps act as a second opinion. At the end of the day, the radiologist has to make the decision, but it can help. So this is a patient. She was a 42-year-old patient. She came from a rural area in Northwest Missouri. She had a screening mammogram, she had a diagnostic mammogram about a few weeks prior at an outside facility, a rural hospital. And then she presented to us with feeling a lump. And that mammogram was red negative. And she did have dense breasts, which can obscure findings on mammography. So we ended up doing a full diagnostic workup. We repeated her mammographic images. We did an ultrasound, and we saw this. So what you can see here is a mass. This dark area is a mass. Well, if somebody looks at this as a radiologist, you might think, I think this might just be a cyst, because typically cysts tend to be anechoic or very dark on ultrasound. But, I thought, but if it's a cyst, I would want it to see it better circumscribed or well demarcated and have smoother edges. I didn't like how this looked. So I ended up wanting to analyze the lesion. So basically what happens is you click on the mass or the area of interest in one view and then the other view, and then you click analyze. So it creates a nice little box around the area of interest, and then you click analyze here. So I clicked analyze, and it showed that it was suspicious. So what's really awesome about this AI algorithm, it's actually linked to, in breast imaging, we have very strict regulations of how we report findings through what's called BI-RADS, which is stands for Breast Imaging Reporting and Data System. And it's aligned to BI-RADS, which is really great. So so basically when I analyzed this lesion, it said, it gave it a suspicious finding between maybe 4A and 4B at 2 o'clock, 7 centimeters from the nipple. So, I already was like, I think I want to biopsy this. She's feeling it. I don't like the margins, but I wanted to see what the AI algorithm showed, and it showed that it was suspicious. So we went ahead and biopsied this mass. And it ended up coming back cancer. So I showed this case to my 60-year-old colleague who's like, why do we need this? We're good at what we do. We don't need AI. So I showed him this case without even showing him this AI result. I said, what do you think about this case? Like, what do you think? He's like, oh, I just think it's a cyst. She's got super dense tissue. That's why her margins, don't look well demarcated. I think you can move on. And I was like, actually, why don't you look at this case? I analyzed it. We biopsied, and this is what we found. And he's like, oh my gosh, I would have totally missed this. I would have totally missed this cancer, called it a cyst, and called it a day. So we saved this patient's life. So this is just one of many cases that I've seen now in clinical practice since we've started implementing this in 2019. And I will be publishing my findings soon. And what we found across, all of our radiologists of all career levels utilizing this is we're able to maintain our cancer detection rate, but reduce unnecessary biopsies by almost 40%. So about over 4,000 biopsies are recommended a day in the United States, and 80% of them are benign, okay? And even then, we have about 130,000 false negatives a year in the United States when it comes to breast cancer. So this is a game changer. And then if you think of costs for the patient, an average ultrasound core needle biopsy ranges from anywhere from $2,000 to $2,500. It can be more depending on what institution you go to. That's huge cost savings, as well as mitigating anxiety for the patient and even the morbidity associated with a biopsy. What if the patient has a blood collection called a hematoma, and then we've got to follow her until it heals? Infection, it's a low risk, but it is a risk. So there are these things that we can eliminate for patients. And I'm seeing this through the power of AI, which has been really remarkable. And we're seeing it at other large institutions as well that are using this algorithm. So I'm just going to kind of fly through this, because Lindsay's gone over a lot, and I know the other presenters likely have similar information here. But of course, we have to be very cognizant of data privacy and security. So with this algorithm, any information that goes to particularly the vendor, it's wiped of any patient health information before it gets to them. So it stays at the hospital, it stays within the firewall, it doesn't go out to the vendor. Biases and fairness, obviously, AI trained on biased data sets may perpetuate or amplify health disparities. And Lindsay, I think, gave a really nice overview of that. And we want to make sure that these algorithms provide parity across all socioeconomic demographics and, whether you're in the United States, whether you're global. And then transparency in data sources and model decision-making, it's really necessary to build trust. Obviously, there are regulatory and legal barriers. Generative AI tools do face uncertainty under existing regulatory frameworks, whether, there's a lot of algorithms that aren't FDA even cleared. Some are FDA cleared. Then you have some that are FDA approved. Our algorithm that we're using is FDA approved. And then liability for AI-driven medical decisions is still a very legal gray area. We had to really work through that in our health system. When I said, hey, I want to bring this whole new novel thing to the hospital, and they're like, what? Because nobody, and still to this day, nobody in the Kansas City Metro is using particularly this algorithm. So it took, I think, a leap of faith in some ways to say, like, it's going to be okay when it comes to implementing this. Clinical validation, many AI models lack the rigorous validation in real world clinical settings. That's something we face. We're seeing a lot of homegrown algorithms, whether it's at Stanford or Mass Gen Brigham or Emory. But how can those apply and have a broad reproducibility across all practice types, socioeconomic demographics? So that's a huge implication we need to think about. And without reproducibility and peer review evidence, adoption, may be limited. Integration with clinical practice. Health systems face technical and even cultural barriers to integrating AI into workflows. At first, when we integrated this tool, it slowed us down. I mean, we weren't just, zipping off and, it was super fast to begin with. We ran into technical challenges. And so it took a little time to get off the ground. So initially, our workflow was a little bit slowed down. And now, it's pretty fast because we've been utilizing it for so long. And also because it is so fast and it's been helping with providing that clinical decision, second opinion, consult support, we're actually able to get at least 2 to 3 more patients in a day for diagnostic evaluations. So that's been really awesome too. And then clinicians may be skeptical or undertrained in utilizing these tools efficiently. So when I first, joined our practice, I was by far, sort of the youngest in the practice. And then here I am saying like, hey, we're going to bring this here and do this. And they're like, we don't need it. Like, we know what we're doing. Between us, we have 100 years of breast radiology or breast imaging interpretation experience. And then, so it took some time, and it takes time to change hearts and minds. But when they start to see these cases and they start adding up and they see, wow, this is helpful, you get to the point where you're like, man, I can't imagine life without this now. So that's kind of where we're at. But it took some buy-in, no doubt. So as far as future implications, just the evolving doctor-patient relationship, what will happen to us? For me as a breast radiologist, I think it will only enhance what we do. At the end of the day, and in my particular subspecialty, there's a lot of emotion that goes with it, and that human touch, that human interaction just cannot be replaced. But we want to make sure that there's this balance with human interaction and that decision-making doesn't deteriorate. And I do worry about that, particularly, with our younger learners. I teach a class, I teach the second-year medical students at UMKC School of Medicine, and sometimes I wonder, like, I wonder what it's going to be like, when they are in my position. So we have to, I feel we have a duty to make sure that that does not deteriorate. Global health equity, as Lindsay alluded to, I mean, there is such an amazing potential here to democratize access to medical expertise in underserved regions. And particularly this one AI breast ultrasound algorithm we're using, they're actually now working with RADA to try to provide this across in concert with ultrasound units in impoverished countries across the world. So there's a lot of implication there to really help find cancers a lot earlier, particularly in countries that have horrible breast cancer death rates. Just the regulatory evolution, governments and agencies are going to have to develop agile regulatory frameworks to really keep pace with the innovation that's happening at quite a rapid pace now. And then Lindsay, of course, is the expert on ethical guidelines, and then continuous learning systems, that adapt based on new data, making sure we have robust safeguards to maintain safety and accuracy and assess for drift, so on and so forth. So in conclusion, generative AI, I truly feel has potential power to revolutionize healthcare as we know it. And realizing, though, its full potential really is going to take a collaborative effort among technologists, healthcare providers, policymakers, ethicists to ensure responsible and equitable integration. Remember that, particularly when it comes to these AI algorithms in healthcare, most of these are not being reimbursed. And that's a whole other topic, which I'm sure we'll touch today. And so that is really slowing down the adoption of some of these algorithms that are ready to go for prime time, because health systems are saying, you're not paying for it, we're not going to purchase it. So that's another issue there. So in closing, not all AI is created equal. There's AI that's been through the rigor of FDA and multi-center reader studies to validate, and other AI still not yet cleared or approved, built with data from a single or select few institutions. Generalizability, AI algorithms need to be generalizable to new populations simulations and imaging systems need to be free of bias. Establishing standard training and testing protocols can determine the generalizability of models. It's important to evaluate the performance of the algorithm as well as the end users when they're interpreting these images with and without the AI system. The ethical use of AI, making sure that these are approved by the FDA, that they are not used for off-label applications. The financial implications, clinicians in hospitals, we might need to really sit down and construct new billing codes. Right now, for this AI breast ultrasound algorithm that we utilize, there are CPT Category 3 codes that we can link to 1 codes, but there is not a Category 1 code. And as some of you may know, if you have to have a Category 1 code to ensure that payers are actually going to pay. And then the future investigations to really evaluate the clinical and financial impact of AI on the healthcare team and patients across healthcare systems. The goal of AI is really augmenting the standard of care without interrupting our existing workflows, making us more efficient at what we do. And like I said, so much potential for us to combat fatigue, burnout, and physician shortages. And, it's important that, particularly us in clinical practice, we can't get frustrated with it. I initially, when we implemented this tool, I had some of my partners would just use it a couple of times and go, I don't want to use it anymore. We really can't use this as a one-off. A use of AI as a one-off will not generate the quality improvements when compared with consistent use. And just like any behavioral change or habit, it just takes time and consistency. So with that, I thank you for your time and attention.
Thank you so much, Dr. Patel. The admin efficiencies, personalized plans, multilingual support are all very, very promising, but I absolutely love that ultrasound use case and the thought of the great cost savings that we all might enjoy one day when this is implemented well. I am looking for Emma Udridge. And Emma, I'm getting your slides ready for you. I really am. Let you take it from here. Thank you. Thank you so much.
Good afternoon, everybody. Can you hear me? Okay. I'm going to time myself so I stay right on target for this after meeting event. Okay, well, thank you so much for having me. My name is Emma Urich. I'm with the Kansas Health Institute, and today I'm going to be talking about developing AI policies. Our previous presenters kind of alluded to this need as we see all this evolving technology, the need for focused and tailored policies at the organizational level, state level, federal level. And so I'm going to be talking a bit more like that or about that within the context of public health and just other health professions, nonprofit work, as well as local governments. So I've been with KHI for about 3.5 years, and in that time, I do state and federal policy tracking. I facilitate various legislative working groups, as well as community-based working groups as well. I facilitate a statewide initiative called Age-Friendly Kansas, and one of the topics within that initiative is actually AI and aging and how AI can be used to augment the work of aging professionals across a variety of disciplines. And then really my interest in AI really emerged in 2023 when the hype really took off around generative AI. And so we've been thinking about AI in the context of public health since then. So if you're not familiar with the Kansas Health Institute, we're a nonprofit, nonpartisan research and educational institution in Topeka. We're right across the street from the state capitol. So we are plugged into policy on a daily basis, as well as monitoring what's happening at the federal level as well and how it might impact Kansas. And part of our kind of mission and what we ground ourselves in, I think, daily and with every project is really committing ourselves to convening really tough topics in health. And as we've seen over the past couple of years, the topic of AI has emerged in every corner of healthcare and public health and as a concern, but also an opportunity to and I can echo what other speakers have said, reduce burnout, streamline efficiencies, and really just help us get the work done. So today in my presentation, I'm going to briefly go over some use cases we've seen with AI in public health, and then we're going to really talk about policy development and some essential components that you can think about at the organizational level, what we've seen in other states, as well as the federal level. And then I'm going to dive into 2 specific topics that we've seen addressed in state and jurisdictional policy, which is data privacy and human oversight. And so public health in an AI era is going to look, different. I think every sector, every discipline is being impacted, for better or for worse. It's a disruptor. It transforms the way we do things. It's an opportunity, but it can be a challenge when you have folks that are resistant to change or maybe have a moral or ethical dilemma around using AI for certain use cases. But AI is a tool, and it can definitely transform our work and turning public health to being proactive, predictive, and really personalized and tailored. And so if you want to ground yourself in the context of public health, it's look no further than the 10 essential public health services. This is a tried and true framework for public health. These are I don't want to say the bare minimum for public health, but these are the tasks and goals that public health professionals, I think, root their work in on a daily basis. And so looking at AI within the wheel of assurance. So when we say assurance in public health, we say that public health services, we assure that those are community specific. They are tailored for the folks that we're trying to serve. So one strategy was developing a chatbot and engaging the community that the public health folks were trying to serve. So a chatbot was designed with community feedback from Black and Hispanic women in a county in New York State. And it really looked at tailoring the messaging and the programming to make sure that the outputs of that chatbot were relevant to that community. I've developed a chatbot before. There's one on the KHI website. I would compare it to having a colleague, and imagine that colleague has a blank mind and you're basically typing an email of everything that they're required to do, how to speak, the language they use, all these different elements. And so having that be tailored and really focused and really programming those cultural specific language and considerations is really important. And we see the impact. This particular chatbot handled over 4,000 messages. It had quite a few social media impressions as well. And it's just another innovative way to tailor messaging in public health to be rooted in community context. So now my favorite part. We're going to be talking about kind of what the AI policy landscape is looking like. We've talked about a need for regulations and other policy to address this evolving landscape. And so at the Kansas Health Institute, we partnered with Health Resources in Action, as well as Wichita State University's Community Engagement Institute to develop it's a mouthful, Developing Artificial Intelligence Policies for Public Health Organizations. And it's a template and guidance. And what this is a really evidence-informed, comprehensive guide to think through organizational policy. And how it does that is it takes in information we've found across the country. So the template and guidance is informed in 3 large buckets. So we looked at 36 states in Washington, D.C., and we looked at over 152 exactly state policies and how AI was being thought of in legislation. We also looked at jurisdictional policies. So that was county and city mainly. Counties, we were having some trouble finding policies, but cities were seeming to embrace and have more discussions and develop policy. And then we also conducted a literature review. We looked at over 96 articles, looking at the ethics around AI in healthcare and public health, and just seeing some ethical principles that we need to be thinking about when developing policy. So this is just a visual to show you kind of the breadth of our scan. We looked at states with introduced policy, pending and failed legislation. And then we also looked at states there in purple that actually enacted AI legislation. You just see Louisiana, Mississippi down there. We didn't find any, but this is rooted in the 2024 session. So 2025, I know there was some emerging legislation. So we'll hopefully be updating the template and guidance soon. And then this just shows the visual landscape of all the different local jurisdictional counties or cities we looked at with AI policies as well. And so from that scan and from the literature review, we really boiled down all of that information into these kind of buckets of knowledge and topics that are commonly addressed in different pieces of legislation and policy. So a few of these up here is looking at transparency, also looking at acquisition and procurement of AI tools for governmental use, state agencies looking to integrate AI into their work and the process they need to do that. Also mitigating bias and what that looks like in policy and practice. And then also today, I'm going to be really focusing in on data privacy. And I didn't even know the others were really going to hit hard on data privacy. So I'm glad I chose that one. And human oversight. So some guidance for policy development. This is really focused at the organizational level. And when we've been giving these talks, we've given plenty of presentations since we came out with this resource earlier this year. But we really started talking with partners about organizational policies and state policies as well. And it's just seeing how discussions about AI were starting to emerge within their organization. So show of hands, who has an organizational policy that talks about AI in the room? Oh, okay. Awesome. Yeah, it could be an existing policy, right? Where you just build AI, or it can be really an AI focused one. So this just really asked, and there's a hand raised, but we can have, I don't know if we have time for questions during or after. So I'm
I think you guys are just letting you know that he has one.
Okay. We'll get there. So some kind of indicators that we've kind of identified during discussion, and just to kind of kickstart the conversation about policy. It's not a chicken or the egg discussion. You can have a policy and then start using AI, but often we see people start using AI and then a policy comes, right? So some indicators for maybe starting that discussion and start formulating a policy, and just plainly, is increase in AI adoption. As we see it permeate every sector, every discipline, seeing all these promising use cases, it's hype, it's exciting, and people want to be a part of it. Also looking at data privacy risks, like we want to make sure you're compliant with HIPAA and all these other regulations that are so important. And then also just lack of clarity around AI use. You can use AI to help you with your email, but you can't use it to visualize data that might be sensitive, or looking at how, if you're a working group, like a facilitator like me, if I'm using it to transcribe a meeting transcript, I kind of like to be transparent that I'm using AI to make sure that I capture everything correctly. So that's just some guardrails there. So just some high level kind of indicators and things to consider for policy development is AI literacy. We've talked about that. Not everyone understands AI the same. It's black box in nature. I think developers often have trouble explaining exactly how AI works half the time. So it's really important it can be an acknowledgement that AI is evolving. You can't, it's difficult to explain sometimes, and that's okay. In your policy too, I think this is my kind of key takeaway for this, is tool agnostic language. When you're developing a policy, what I mean by that is not focusing on ChatGPT 4.0 or Pedal AI or Copilot in your policy, because tools are evolving every day. It seems like a new tool comes on the market. It's being integrated into Google, search engines, Microsoft Suite. So having a policy that remains relevant and really focusing on maybe just what you're hoping the AI will accomplish. So is it pertaining to generative AI? Is it machine learning? Is it another form? So just keeping that in mind when developing a policy. And of course, keeping compliant with all the existing regulations and policies that you currently have, your legal team. I know that can be sometimes scary. And then also just making sure your policy remains adaptive. It's clearly defined in its scope. Determining if it pertains to the organization as a whole, or maybe specific departments, or depending on the function of a department or a position, maybe their use looks a little different. And then also if it's just feasible to do. So if it's overwhelming, I know we've had a few hands raised that they currently have an AI policy at their organization or wherever they are coming from. But we have a sample outline within the template and guidance to help think through policy development within these key outlines. And then I'm just going to go over now. Ooh, I'm still on time. These 3 buckets. So the template and guidance is really framed with the purpose. So why you're even thinking about an AI policy, guiding principles within your organization that your organization wants to adhere to, and then also topic-specific provisions that we identified in state jurisdictional policy as well as within the literature. So some samples of purpose statements we can think about when developing a policy is identifying specific objectives that your organization wants to achieve with AI. And a lot of that is going to come from some pre-work and discussions within the organization to determine the rationale for AI use. Is AI even the right solution for the problems that we're trying to solve? And then just overarching, what do we want to achieve? How is integrating AI going to make our work, our organization better? Also thinking about strategic objectives as well as a commitment to responsible and ethical use. And that can look different for every organization, as it should. But we hope that this template kind of gets you started thinking about, and I'm not going to read this sample provision verbatim, but this just gives you a flavor of kind of what other states and cities are thinking about when they were thinking about their policy and developing it. And these are real examples that we've pulled from policy for your reference. And then these are just some sample guiding principles you can think about, and that this also will look different depending on your mission and vision. But this first one I like, it's AI systems. They don't possess judgment or moral understanding. They are tools created by humans, guided by humans, and humans ultimately bear the full accountability of whatever it generates and however it's used. So I really like that one. And then the second one is really, as previous presenters have said, AI augments the work. It doesn't replace the human. So there's a lot of kind of fear potentially around workforce replacement with AI. And we've seen this at the Department of General Services Administration recently with the implementation of a chatbot and was trained on different functions. And so, stories like that, it creates a bit of unease with especially the public health workforce, which is already strained and suffering from burnout and a lot of work, as well as healthcare systems as well. So we know that. But these can help have those discussions with staff, hear concerns, and also still maximize opportunities. So I'm going to hit on some data privacy specific provisions. So within these buckets, we found in state and local jurisdictions, and as well as the literature, some ethical use of AI is ensuring that confidentiality, security, and legal compliance remains at the forefront. So what that can look like in a provision is just prohibiting users from transmitting personal, sensitive, or protective information. Specifically, this one looked at generative AI tools, but you can be more specific or broad. The second one really looks at handling sensitive and identifying information. So really just a blanket prohibiting of including confidential information into AI prompts. And then the last one is an opt-out of data collection. So many publicly available AI tools, you can actually go in on the back end and select, I don't know the exact language, but you can opt out of them using whatever you're putting into it from using it to train the system or improve responses. So depending on the nature of your work and you're using a publicly available tool, you can opt to do that. And I do want to note at the federal level, there is no federal mandate requiring developers or AI systems to disclose how they're using the data to train the system. Just a thought. So human oversight, a few sample provisions we included. This looks at oversight processes and protocols. It simply put, human in the loop, just putting a human in the process to review the outputs before it goes out, looking at maybe the prompt that was used to generate the response, making sure that it was engineered to kind of do what it needed to do. Also putting accountability for the human, and also establishing various levels of oversight depending on the risk of the activity. So when we say risk, low risk is maybe modifying an email that you're sending to a close partner or using it to summarize an internal meeting transcript. High risk, maybe using survey data, and you still de-identified things, but there might still be some identifiers in there. And maybe you're trying to do a data visualization in ChatGPT. Maybe that's a little more medium risk and requires a conversation or a little bit more oversight. So this, I'm at my time. And so it's a great resource. If you're interested, I'd love to hear if you use it, if you have conversations about AI policy within your organization. I'd love to know what that looks like. I'm sticking around for questions, and thanks for having me.
Thank you, Emma. I know many are going to want to look at the template and guidance resource. I'm positive of that. And next we have Samantha Birch. She goes by Sam. Bear with me, Sam. I am tootling with technology.
That's been my entire day, Pat.
All right, please feel free to share your screen.
Right. And please let me know if this is showing up correctly.
Will do. You are in great shape.
Fantastic. Thank you so much. I really enjoyed hearing from the previous speakers. I think you're actually going to hear a lot that transcends across these presentations in terms of our views on AI generally in healthcare. I know I'm here to give the industry perspective. I am sitting right downtown in Washington, D.C. Sorry, I can't be with you in person, but excited to sort of share some of AHIP's thinking on this. And we really lean in very heavily on our members, obviously, expertise and experience. For those who aren't familiar with AHIP, we are the leading association that represents health plans. Our members collectively provide coverage to more than 200 million Americans. So I think really a great snapshot of sort of where the industry is in terms of AI and Gen AI in particular. So kind of starting macro and then maybe going a little bit more micro, sort of how are health plans using AI today? I mean, we have sort of three buckets, I think, of use cases. The first, and obviously, I think one of the most important, consumer, clinical, and administrative. So this slide just lays out some examples of how health plans are leveraging AI in everyday use, whether it's virtual assistants or to support research or personalized care, data integration, interoperability. I think this one is a growing and really exciting part of the work, and obviously the analytics piece that is incredibly valuable. And then in terms of administrative, we are seeing a lot of exciting use cases around prior authorization approvals, speeding that part of the process. How do we reduce costs and really leverage emerging technologies to support not just the back end part of health plan operations, but also, most importantly, the providers and the patients. So digging down a little bit into generative AI, obviously we all know that it goes beyond prediction and can really create some great opportunities to speed up the processes happening behind the scenes. So whether that's summaries or draft prior authorization requests, as I was sort of pointing out that use case, chatbot responses, And really what we're driving towards is efficiency, member experience, and reduction in administrative burden and costs. And I love, and I think Lindsay laid this out at the very, very beginning, but I can speak to this too. I'm a brain tumor survivor, right? So the healthcare system has been an integral part of my life, since 2010 and before that, but in a very meaningful way since. So how do we really leverage emerging technology to make the experience more seamless for patients? And like I said, I have a personal stake in that as well. So some key use cases around Gen AI in the health plan space is automated member communication. I think everybody has had, up to me included, sort of that very prolonged experience on the phone with their health plan, trying to get whatever answer it happens to be. And we're really seeing a lot of promise in sort of automating and speeding up how we get the right information to the right member, consumer, patient, wherever you might be in the process at that time. And also sort of support, right? As I was pointing out on prior authorization, but it goes beyond that as well. I always like to say, even when we get to the claims piece, right? If we had trust and standardization in the system, we wouldn't have clearinghouses, right? So this is an amazing sort of, I think, use case and opportunity when we think about sort of, the whole spectrum of the administrative part of healthcare. And I spent many, many years on the provider side. So by way of background, I worked for the American Hospital Association, Federation of American Hospitals. I was with HIMSS for several years. So I've really seen all sides from the health IT perspective in terms of sort of the policy and politics of it. And then obviously, again, sort of the AI assistant piece and the appeals and internal documentation. I mean, healthcare obviously can very much benefit from streamlined communication, bringing more sort of seamless experience to patients and as well as providers. So this is, I would call this a snapshot. I would not call it conclusive in any way or exhaustive, but as I talk to our plan members, what do they talk the most about when it comes to safe, effective, efficient AI adoption? And I don't think this is in any way exclusive to Gen AI. I think this is really across the board, probably, right? When we talk about cross-functional governance, right? Or we talk about creating pilots with safeguards. I hear this all the time from our AHIP members, is that they are really, when you've seen one health plan's AI adoption, you've seen one health plan's AI adoption. Organizations and companies are in very, very different places on this, right? And rightfully so. But one thing, if you, to the extent that I talk to all of our members, they say that where we started, right, was with pilots with very strong safeguards. And then the auditability and explainability piece into tools, sort of, how do we know that what we're getting is what we're getting? And, what are the decision points that are coming into that? And I think this really becomes challenging because, and I think it's been brought up a couple of times, we have this issue with the developer versus deployer, and we don't have good standards around sort of accountability in that space. And it's, not at all to say that we're going to figure that out anytime soon. But it does harken back to the early days of electronic health records, right? As we were implementing new technology and sort of how do we figure out who's responsible? And the plan world has been really interesting to me because on the provider side, you have a lot of buy, not a lot of build. relative to the plan side where you have far more build, internal development that happens. So again, these issues become really interesting. And then workforce, right? It's been brought up several times, so I won't harp on that. And then the importance of multi-stakeholder collaboration. I mean, working with the regulators. I, again, mostly focus on the federal level, although AHIP has many, many talented people who spend a lot of time quarterbacking and triaging the immense amount of work happening at the state level. But really, how do we, best shape policy and practices and getting the resources to the organizations that need it the most? We don't need another digital divide in this space. We need to learn from, the lessons of the past, right, in terms of technology adoption in healthcare. So you can find this also on the AHIP website. We just released a one-pager and infographic that really lays out sort of our policy recommendations. I don't think you'll see many surprises here, but really focused on a federal approach. We think it's incredibly important. And again, this is all public policy focused because that's the core of what AHIP does, not the core of what I do. Defining AI, right? And having that be standardized. We need to fill gaps. We don't necessarily need to get de novo in certain areas of existing law. So for instance, OCR in their HIPAA security rule update laid out several examples of how the current security rule applies to emerging technology. That was a great step forward. High level oversight, risk-based approaches, protecting intellectual property. Again, that gets to the build versus buy piece. Public-private partnerships, I think, are a major key here. And advancing standards. This is, the one thing that we think about as we look at sort of what the trajectory is of some of the restructuring that's happening at HHS is what does that support for standards look like? And then guarding privacy. I mean, we need obviously a comprehensive federal consumer privacy law. I've been talking about this for 18 years at nauseum. So yes, I was 5 years old when I started. No, just kidding. But this is core to this issue, which is healthcare is not in a vacuum, right? And AI is not healthcare specific, right? So while we would like to see more HIPAA compliant tools for our smaller providers and other parts of the healthcare system, I mean, we have a long way to go here. And it's going to have to be part of some sort of larger privacy construct. So I'm going to stop there. This has my information on it. Please feel free to reach out, LinkedIn or whatever, but really just want to thank Pat and the team for inviting us to participate.
Samantha, thank you so much. And thank you again, Lindsay and Amy Patel, Emma. Thank you all so very, very much for saying yes today. Again, we are very, very grateful to Health Forward Foundation, BioNexus, Frontiers, and our friends at Digital Health KC for the very special invite this evening. I know that you have adult beverages waiting for you, but take a minute and have cookies. We have a lot of cookies left back there. And we're also really, really grateful for the caliber of expertise of those who have said yes to presenting at IQ forums, and to those who have helped, and many of you are in this room, who have helped us connect to them. Thank you so much for that. Want to remind you that the next forum is July 17th, Emerging Trends in the Health Insurance Industry. So I hope you'll register for that. And let's see if we have any questions in the room. I'm going to attempt to, while you formulate your questions, I'm going to attempt to turn the camera around because I got word that the room camera isn't room cameraing. And I am not finding how to do that, so
Hi, Patricia. This is Shelby. I think it's just that it's been turned off, not that it's not that it's not in the right angle. It just looks like if you go to your Zoom settings, the camera isn't on.
yeah, that simple thing. Oh dear. Well, there you have it. The camera's on now. You can questions. Let's see what happens. And yeah, if there's a question specific to you or you hear one and it's burning at you and you just want to answer that one, please do. This is casual. I saw a hand.
I think it's fascinating, the AI that we're using. I've exited healthcare and the revenue models that used to exist in, but when we have a great doctor that is reducing biopsies by 40% and hospitals working on such thin margins, is anybody discussing the revenue effect of AI and its pull down on the hospital? An old CEO would say, good revenue, Dave, because my parking lot's full. Right? Now we have AI saying it's good revenue, Dave, but she's reduced procedures by 40%.
We have a presenter that wants to address that because I can.
I was like,
Oh, yes, that is obviously something that I think the C-suite is looking at, and especially now within margins. But my argument is, particularly if I'm able to not do biopsies on those patients, I'm able to get more patients in for screening and diagnostic mammograms, and the number of those that equal the time it takes to do an ultrasound core biopsy, actually you're going to generate more revenue. So, I work for a nonprofit hospital, but at the end of the day, nonprofits have to break even. And so the dollar is always the bottom line. And so we're able to show them now through the revenue cycle. And I had briefly touched upon particularly that, because we're using this tool, we're able to get in a few extra patients a day. Those are diagnostic patients. So that includes a diagnostic mammogram and an ultrasound. So that is an additional cost, and it's covered by insurance. And so, and right now, this algorithm isn't covered by insurance, that we're working on it in the market. We're seeing that payers are covering this, particularly in certain pockets. The East Coast is one of them. A lot of payers are paying in New York, anywhere from Medicaid, Medicare to private insurance. So we're working on it in the metro, but for now, there's no reimbursement. But that is kind of how we're justifying it, and we're showing the numbers, and that's how I'm able to keep it.
Thank you for that. Thank you. We have a question online for Sam. I'd love to hear more about about how the industry is approaching the human oversight of automated decisions, especially as it relates to prior authorization approvals. How are consumers interacting with automated decisions, and do they have any sort of guidance on how to appeal decisions?
yeah, sure. I appreciate that question. I think generally speaking, what we've heard from our members is that, AI is very much being used for prior authorization appeal or prior authorization approvals. It is not being used for any type of denial based on clinical factors. So that's sort of the bright line. In terms of consumers interacting with automated decisions, I think health plans obviously institute their own sort of frameworks around transparency and governance. But I think this is a work in progress, very much so. And it's sort of this, industry interaction about what are best practices in the space. So the Consumer Technology Association, we work very closely with, and AHIP works with a number of standards development organizations, and really it is getting to some type of streamlined expectation, right, for consumers around what you can expect. And so I think this is an exciting space, but at least in terms of bright lines around how AI is used in that process, I think we're fairly confident, that at least for clinical decisions, there's humans in the loop.
Thank you, Sam. Other questions? Yes.
This is another one for Dr. Patel. It's been demonstrated that algorithms age. And I'm wondering, you had indicated that the algorithm you were speaking about was from 2018 or 2019. In that time, how much tweaking have you had to do to that and to prevent decay? And how do you manage that over time?
Yeah, that's great. So I think that drift is something that we are very cognizant of when it comes to these AI algorithms and clinical implementation. And so we are constantly assessing for drift with the vendor. So I know that, depending on the algorithm, I think all vendors right now in general, or whether it's homegrown or working with the vendor, they should be anyway, assessing for drift very frequently, not like every few months, but like, every week, every 2 weeks, every 3 weeks, looking to make sure that the algorithms that we're utilizing this for are intended to be, are for its intended use rather. So we're constantly monitoring that. We're constantly in discussion with the vendor about that. But, I haven't seen, in working with the vendor, we haven't seen any